we'll now move on to the next talk by Dr. Pradeep Sharma, who will be speaking on managing wriggly eyes and getting the best of nystagmus evaluation. And sir, of course, needs no introduction with his talk. Sir, please.
Okay. So thank you very much, Dr. Rohit, for that introduction. And as the topic is mentioned, that's managing wiggly eyes and getting the best of nystagmus. In a short time, we need to just understand that nystagmus is a rhythmic, regular oscillation of the eyes. And we should always rule out a physiologic nystagmus, which may be an optokinetic railroad, vestibular endpoint, or a voluntary nystagmus. And we should also distinguish nystagmoid movements, which are irregular, and these are not rhythmic. And these may be like the HB phenomenon or the convergence retraction or opsoclonus. The nystagmus in childhood, we will see in these categories, the sensory nystagmus, which is usually requiring an eye examination because they would be having some problem in the vision. So look into the fundus, and ERG and other tests may be required. The more commoner one that we see is the infantile nystagmus syndrome, earlier known as congenital nystagmus or a manifest nystagmus. But mind you, this is not congenital, and we should call it an infantile nystagmus syndrome. The second commoner one is the fusional maldevelopment nystagmus, also known as the manifest latent nystagmus. And a third, which is less commonly seen in infancy, is the nystagmus blockage syndrome. There are some other which are marked in red because you need to remember that Spasmus nutans or a seesaw nystagmus or a vertical nystagmus in a child should always require an imaging to be done to rule out an intraocular space occupying lesion, intracranial space occupying lesions. So if you have a sensory pendular nystagmus, which looks like this, to and fro movements, now these are going to be having some problem in the retina. So look for the fundus and order an electroretinography or an EOG to find out the cause. The infantile nystagmus syndrome that we see more commonly is a bilateral conjugate uniplanar horizontal mostly nystagmus. And as you see in that video, a child may have triangular waveforms in the initial first 6 months or 18 months, and then it becomes a jerk nystagmus. It's important to see in these children that we should distinguish an adduction null. Many of them will have a null which is eccentric from the primary position. Now this child, as you see, has a face turn to the right and a null. When I covered the right eye, which was in adduction, he still maintained the head posture, meaning thereby that this is an eccentric gaze null and not a adduction null. How does the adduction null look like? This one. Now this is the other child who has a manifest latent nystagmus. Now he is now fixing in the right eye. I covered the right eye. Now what happens? He is going to switch his face turn and take up the left adduction null. So this is typical of a manifest latent nystagmus. Whereas the first one which you saw was maintaining with that, so it was an eccentric gaze.
Dr. Pradeep, he is one of the best.
Yeah, there's some crosstalk, I think.
Please keep mute all the speakers. Yes.
The manifest latent nystagmus may also be having an associated squint, like this girl who has an intermittent divergent squint. And see what I do when I break the squint with the Spillman occluder. The moment the IDS becomes manifest, there is a manifestation of the nystagmus also. Now, this case, if it is so, then we just need to correct the squint. Infantile esotropia may have an associated Ciancia syndrome or IENA. What this has is that they have a adduction null fixation, and this may require, in addition to the esotropia correction, a posterior fixation or a farden on the medial recti in order to correct the head posture also. The examination of nystagmus thereby would be looking for the head posture for distance and near both, looking for associated albinism like this girl has, or any associated squint. And the face turn, if it is there, then you need to measure how much is the face turn. There may be a periodic alternating nystagmus, which may keep on changing every 3 to 5 minutes. So observe such children for at least 5 minutes in a constant manner in order not to miss a periodic alternating null nystagmus. The vision would change in the null position, as also if you cover one eye in a manifest latent nystagmus. So a bilateral vision assessment should always be done in such children. A Spasmus nutans child will have an asymmetric nystagmus like this. They usually have a head tilt, torticollis, and a fast moving nystagmus in the left eye, as you can see, with the larger amplitude. Have a closer look. You need to always keep Spasmus nutans in mind in a child coming at 1.5 years of age. And if there is, always do a ICSOL exclusion, a chiasmal glioma by a CT or an MRI. A nystagmus blockage is less commoner. So in childhood, you need to keep on these points, which I just talked about. An electronystagmography, if it is available, you can do. Video nystagmography can be done, and we can see the pattern of the nystagmus and find out more details about what is the type of nystagmus and what is the foveation dynamics. And acquired nystagmus would require for other things. In non-surgical management, the proper glasses, tinted if albinism, contact lenses, prisms should be given, and auditory biofeedback and acupuncture have been used. But the most gratifying results are from the surgery if there is an eccentric gaze null, and these are by the Anderson-Kestenbaum group of procedures. Our choice is to do a augmented Anderson's procedure, in which the medial rectus is augmented from 6 to 9 actually, and lateral rectus 12 millimeters as a yoke muscle surgery. And this gives us very gratifying results. As you see here, the head posture is corrected and the nystagmus gets damped. Now, this is a pre and post video, and these are the recordings. In a missed periodic alternating null nystagmus, you may have a switch of head posture. If you have done an augmented Anderson's, there's nothing to worry. You can do the other two yoke muscles, and it will resolve the problem in another 24 hours. If there is an associated squint, you have to take care of that squint. And same is this thing for chin up or chin down, or a torsional Kestenbaum procedure, which may be done if there is a eccentric null in different ways. Procedures like 4 muscle resistance and the Hertel Veloso have not been of much use. So I think the conclusions are that you need to tackle the augmented Andersons for up to 30 degrees. More than 40 degrees, resections may be added. And if there is a pan, you do a bilateral augmented Andersons. If there is any associated squint, correct that, and that may correct the nystagmus also. And if there is no definite null, we are still looking for an answer. Thank you all for this patient listening.
Thank you very much. Dr. Rohit, you're there. Do you want to take a question, or shall I ask?
Go ahead, ma'am. Sure.
I'll ask the question. You are the man to ask.
Any role of pharmacological modification for nystagmus, Professor Pradeep Sharma?
Yeah, I think that slide which I was showing, that in the non-surgical ones, pharmacological modifications in the form of baclofen in the acquired pan can be done. That video, okay. It was not allowing me to have my video. So the baclofen can be used for acquired pans, and also drugs like the brinzolamide. I think there is a study by you yourself, which has been done in one of the theses that we did. I do not see much scope of that, although Dr. Hertel keeps talking about some magical results with some magical potion which can be used, but we are still waiting for that to come up. So as far as medical treatment is concerned, gabapentin or baclofen have still some effect, but others are still, we have to look for.
Is there a surgery for head tilts effective?
Yes, the head tilts can be corrected by, I mean, what we use is the oblique muscle surgeries, but people do shifting of the horizontal muscles vertically, or some people do the vertical recti shifted horizontally to correct the head tilt, which is causing the null.
For an acquired periodic alternating nystagmus, would you think of surgery if the medications fail?
We should try baclofen, and if suppose the baclofen is not working, then we can do the surgery, which will be the 4 muscle, horizontal muscles, supramaximal recessions. But you would do a neuroimaging before that? Always. In acquired, we'll have to look for the cause. It may be a post-traumatic, or it may be some intracranial space occupying lesion. Yes, ma'am.